Hi Ashrita.
Hi, Kirti.
So what do we do?
Hello, I'm Dr. Ashrita. I'm a neurodevelopmental and behavioral pediatrician. I'm currently working for Andhra Hospital Child Developmental Center, Vijayawada and Visakhapatnam. And what do you do? And where can we meet you?
I'm Dr. Kirti. As you said, we are in the same field, neurodevelopmental chapter and also adolescent health. You can reach us at Milestones CDC Vijayawada for all the developmental issues and adolescent health. So why are we here today?
So basically, we are going to talk in this podcast, in the series of the podcast, about neurodiverse children and their problems, to advocate awareness among the same thing, and also to support them and raise the awareness in the community and discuss our own problems regarding dealing with these children.
Definitely.
Why we have started this podcast in April?
So basically, April is Autism Awareness Month. Specifically, we celebrate Autism Awareness Day on April 2nd. But the purpose of this Awareness Month and Awareness Day is to bring more awareness in the society and for the parents, for communities, for medical field people and even pediatricians, because definitely there is a rising trend in the autism issues and also other developmental issues. Now, if we see in general population, I don't know if it is because of the awareness or is it because of the social media influence or the availability of so much of knowledge for parents and normal community people. So that's why we are here today.
To guide them in a right.
Yeah, to guide them in a right way.
Right. So basically, we have started this podcast in April because April, the whole month, is celebrated as Autism Awareness Month, as you already know, and she mentioned. And April 2nd specifically is celebrated as World Autism Awareness Day. And there is an increase in trend. 1 in 36 children are facing this issue. And we know there are many reasons, and we are going to discuss all your frequently asked questions in this podcast.
Yeah, even some myths and facts, and
we are going to break your bubbles around the myths, and we want to answer most commonly asked questions around the therapies and everything. So I think we are going to run into this podcast.
Yeah.
How early we can diagnose autism, Kirti?
So diagnosing autism, the real diagnosis we can give about 3 years of age, but as early as we can notice signs and symptoms at home as early as 1 year, 10 months itself. While breastfeeding, the mother can notice the eye contact of the baby, the name call response, and certain milestones what they achieve by 9-10 months, like waving bye-bye, giving eye contact to the mother, responding to the mother's voice, basically the language and social milestones. The diagnosis is made at 3 years of age, but we can definitely notice the features of autism as early as 10 months. But we generally do screening around 18 months, 16 months. So we talk a lot about red flags, signs and symptoms, features, social language delay. What are these? How to notice this? How to give guidance to the parents to notice these signs and symptoms at home?
Generally, autism ante interaction and communication problem. They andaru speech delay anukuntaru, but it is not speech delay alone. So it's an interaction and communication problem, and early signs no annattu less than 10 months lone we can identify. So the main important red flag is eye contact, poor response to name call, staying aloof, వాళ్ళలో వాళ్ళే ఆడుకోవటం, repetitive activities చేయటం, అంటే going round కానీ లేకపోతే ప్లేయింగ్ a similar game in a similar style, so లేకపోతే hand flappings, toe walking, all this comes under this repetitive behaviors, and also sometimes blabbering blabbering some nonsense like unnecessary meaningful words, which we term it as echolalia. And also they are not mingling with other children, especially with any other person, and they are playing by themselves. So the red flags are like eye contact undadu, communication issue vachesi, they will not going to communicate with you, they stay aloof and they play among themselves, and there are certain repetitive behaviors and also sensory concerns like closing ears, mixer sounds, cooker whistle sounds kani, and visual concerns like ఒక ఐ మొత్తం డయాగ్నల్ గా చూడటం, ఐబాల్ మొత్తం డయాగ్నల్ గా పెట్టి చూడటం, ఇట్లాంటివి, టో వాకింగ్, ఆల్ దిస్ కమ్స్ అండర్ సెన్సరీ కన్సర్న్స్ అండ్ రిపిటేటివ్ బిహేవియర్స్. అండ్ ఆల్సో
call it as a spectrum. Why is it called autism spectrum disorder?
సో బేసికల్లీ ఆల్మోస్ట్ లైక్ ఎవ్రీ సిమిలర్ అంటే mild, moderate, severe, everybody is considered under autism. Very mild symptoms లేదా at risk for patients నుంచి మనం తీసుకొని diagnosed patients వరకు, diagnosed children వరకు అందరూ autism spectrum లో వస్తారు. సో ఇట్స్ అ వైడ్ వెరైటీ ఆఫ్ స్పెక్ట్రమ్. సో ఎర్లీ సైన్స్ లో ఇంకా వాళ్ళకి డేంజర్స్ అర్థం కాకపోవటం, ఇంకా ఎమోషన్స్ అర్థం కాకపోవటం, ఇవన్నీ కూడా మనం ఎర్లీ సైన్స్ గా చూడొచ్చు. అలాగే నువ్వు అన్నట్టు స్పెక్ట్రమ్ లో సో ఎమోషనల్ కోషంట్ హై లో ఉండొచ్చు, తర్వాత కొంతమందికి బాగా అర్థం అవ్వచ్చు, కొంతమందికి అస్సలు అర్థం కాకపోవచ్చు. అంటే దట్ ఈస్ వాట్ ఐ సెడ్, హై ఫంక్షనింగ్, లో ఫంక్షనింగ్ ఆటిస్టిక్ చిల్డ్రన్ ఉండొచ్చు. ఇంకా చెప్పాలంటే కొంతమందికి ఎస్పెషల్లీ కమ్యూనికేషన్ డిలే ఉండొచ్చు, ఇంటరాక్షన్ బాగుండొచ్చు, కొంతమందికి ఇంటరాక్షన్ బెటర్గా ఉండదు బట్ ఎక్స్ప్రెసింగ్ బాగుంటుంది. సో ఆల్ దిస్ కమ్స్ అండర్ వన్ సింగిల్ స్పెక్ట్రమ్, దట్ ఈస్ ఆటిజం.
And just not only social and language milestones, I feel even play, imitation skills, even activities of daily living, we generally see those milestones are delayed in these children.
Yeah.
If it is not,
It is affecting the learning of the child.
yeah, in all the areas.
In all the areas. So social activities are disturbed.
Yeah.
Major issue is interaction and communication. It is affecting all the social skills of the child, which includes whatever you said.
Yeah.
మనం వీటిని ఎలా స్క్రీన్ చేయొచ్చు, ఎలా అసెస్ చేయొచ్చు, దానికి స్పెసిఫిక్ ఇది ఉందా?
There's so many screening tools, but what we generally normally follow in a routine busy practice is MCHAT, and it has to be done. It's made compulsory around 18 and 24 months. And MCHAT, as you know, it's a parental rating scale. It's just very easy. It's available in so many regional languages. It's only yes or no questions, and there is also MCHAT follow-up which can be done by us or a pediatrician and ask the similar questions and mark 0 or 1. And there are other screening tools like ages and stages, even LEST language.
PDS and simple
Yeah,
PDS
simple.
and LEST scale can
Yeah.
also give. And especially నువ్వు అన్నట్టు MCHAT చేసేటప్పుడు బిజీ పీడియాట్రిషియన్స్ ఉంటారు, ప్రాక్టీషనర్స్ ఉంటారు. యాజ్ షీ మెన్షన్డ్, ఇట్స్ పేరెంటల్ సెల్ఫ్ రేటింగ్ స్కేల్. సో యూ even though parents కాకపోయినా your staff can do it, right? Your staff can do it and we can screen the children. So 18-24 months, MCHAT, ages stages questionnaire, TDSC list.
And also, why screen so early? Why screen around 18 months and 24 months? Why so early?
Why so early? Picking up early will give you a better result because your age, your neuroplasticity is there. So all this will help you to make the child move out of the spectrum. So current trend is early detection and early intervention. Yes. So that's why early screening. నిజంగా అవసరమా? ఎందుకంటే ప్రతి ఒక్కరు చైల్డ్ పంపించినప్పుడు కామన్లీ ఆస్క్డ్ క్వశ్చన్ పీడియాట్రిషియన్, మీ దగ్గరికి పంపించేదే అసెస్ చేయటానికి కదా, మళ్ళీ అసెస్మెంట్ స్కేల్ ఏంటి? వై వి నీడ్ దట్ అసెస్మెంట్?
Definitely assessment is necessary. First thing, మనకేంటంటే to understand the functioning of the child. Even though child is 2 years old or 3 years old, but the functional age might be around 9 months. అంటే the child does not have eye contact, name call response. I cannot start the therapy or I cannot deal the child as 2-year-old. I have to definitely start my working on the milestones from where the child is functioning. So this is called theory of Vygotsky. So generally the therapies are based on that, and definitely functional age is very important, and also to look into if there are any other comorbids, or does the really child fits into spectrum or risk for spectrum, or is it just social communication delay, or is it just there are differential diagnosis, as you know, for autism spectrum, like ADHD, early risk for ADHD, or intellectual disability, and where we see.
So basically, we do this assessment to find out the functional capacity of the child, and also recently this assessment is made mandatory in India after 3 years of age, especially by considering ESA.
Yeah.
సో అసెస్మెంట్స్ ఏమేమి ఉంటాయి, ఏమేమి చేయొచ్చు, ఏది కంపల్సరీ చేయాలి, ఎందుకు చేస్తున్నాం?
So assessments are compulsory to understand the functional age of the child. Even child is coming to you at 2 years, 3 years, 4 years or 5 years, but functional age అంటే చైల్డ్ మైల్ స్టోన్స్ ఇప్పుడు ఎక్కడ లెవెల్లో ఫంక్షన్ అవుతున్నాడు అని తెలిస్తే ఫ్రమ్ దేర్ వీ హ్యావ్ టు స్టార్ట్ వర్కింగ్, అండ్ టైలర్ మేడ్గా ఒక ప్రోగ్రామ్ ఫర్ దాట్ చైల్డ్ షుడ్ బి మేడ్. ఇట్స్ నాట్ లైక్ దేర్ ఇస్ one this thing that every child of autism can fit into ani ledu. So that's why we should definitely know the functional level of the child to start the therapies and to schedule the therapy plan for that particular child. So there are so many assessment scales for functional, like VSMS will help, and DST, DDST also will give us some amount of where the child is functioning anedi, and diagnostic tools like ADOS, INCLIN, ISA, CARS, GARS, these are also accepted by RCI, Registrative Council of India, for diagnosing the autism spectrum disorder.
So basically assessments are really required, one for the therapy point of view, and also the second thing is government has made it as mandatory for them to make a diagnosis after the age of 3 years, so that they can get some benefits from the government itself. Yes. Like UDID card, for example state lo aithe Sadram applications, all these things will provide as a source of help to the parents and also to the child to get their resources, right? So that is why assessment is more essential. That is why the developmental pediatrician and a psychologist orders for an assessment. Yes. Not for any other purpose. This is the main purpose, right?
And also coming to sensory issues, not every child will have all the sensory issues, and coming to sensory issues, it can be hyper or hypo. So knowing that,
put the child in hyper or hypo, and then again we will tailor this therapy according to the child sensory concern.
Yeah.
And we will do the integration.
Which sensory concern does this child particularly have, and work on the hyper or hypo, so we can schedule. That's how the tailor-made program is made. In the even the sensory integration therapy part.
ఇప్పుడు మనం ఇవన్నీ డిస్కస్ చేసాం కదా, ట్రీట్మెంట్ పార్ట్ లోకి వచ్చేసరికి ఫస్ట్ మెడికేషన్స్, బికాస్ ఎవ్రీబడి ఈజ్ ఇంట్రెస్టెడ్ ఇన్ మెడికేషన్. సో ఏమేం మెడికేషన్స్ ఉన్నాయి ట్రీట్ చేయడానికి ఆటిజం?
So as you know, to treat the core autism spectrum, there are no medicines. It's only, we believe, through therapies the child can improve, definitely because of the neuroplasticity. But there are medicines to treat comorbids like attention problems unna, leda sleep issues, diet issues, or hyperactivity issues, or maladaptive behaviors like self-harming behaviors, or such comorbids treat cheyadaniki we take help of medications tappa, not to treat core autism. There are no medications. And how about nutraceuticals?
So all these nootropic drugs or nutraceuticals like omega-3, pufal, carnicin, all these are like brain supplements gani. They are not going to create magic in autism. They are just side characters or side heroes to support your all these things, but it is not going to change your behaviors. It is not going to create interaction or communication. But yes, if you can generally see if the child is low functioning or having any other comorbs like epilepsy, epilepsy or anything, you can suggest all these things. But these are not the main superheroes. The superhero is only థెరపీ. సో ఇంకా చెప్పాలి అంటే డైటరీ థెరపీస్ కూడా ఉన్నాయి, లైక్ కెసిన్ ఫ్రీ, గ్లూటెన్ ఫ్రీ డైట్స్. దీస్ ఆర్ ఆల్ నాట్ ప్రూవెన్, బట్ దీస్ మైట్ ఇంక్రీజ్ ద హైపర్ యాక్టివిటీ అనే ఒక థియరీ ఉన్నది కాబట్టి దే ఆర్ ఆల్ సజెస్టింగ్. బట్ సి, ఇట్ మైట్ డిప్రైవ్ ద చైల్డ్ ఫ్రమ్ ఆల్ ద బేసిక్ vitamins and minerals. So I am not going to recommend all these things, or the science is not supporting all this casein free and gluten free diet also.
So especially the children who has dietary issues, who has particular allergies towards casein or
for them we can suggest not to have those kind of,
after having a proper gastroenterologist consultation and
routine follow up aina tarvata we can suggest them whatever is required for that child.
Not for every child, not for every child who has autism, or not for every child who has constipation in autism, we're gonna suggest these diets.
So it is not recommended, and it is highly child based or child dependent thing, that is. మనం ఎలాంటి థెరపీస్ చేస్తున్నాం మన CDCs లో? వై వి సజెస్ట్, వాట్ కైండ్ ఆఫ్ థెరపీస్ వి షుడ్ సజెస్ట్ టు ద పేరెంట్స్ అంటారు?
See, there are so many names like early intervention ani, early stimulation ani, behavioral therapy, occupational therapy, sensory integration, ABA therapy. Atlaga there are so many names for these therapies. There are so many institutes follows different variety, but the core approaches. Yeah, exactly. So the major funda of all this is we should understand where the child is functioning, and we have to start the therapy or work on the next milestone what the child is about to achieve. Like how physiotherapy, we cannot work with the child directly on walking. We have to, they first crawl, then sit, then stand, then walk. So like that there are we cannot like jump the milestones. Definitely it's social interaction first, then comes the interaction and language. So it's definitely not speech or articulation defect the child is going to have. So even in behavioral therapy we basically work on the milestones which the child is about to achieve next or should achieve next. So if you know the functioning of the child, we can tailor make the program. So if, let's say child is functioning around 9 months, so what behavior do we expect? It's more of eye contact, it's more of name call response, it's more of interaction, social smile. So child bringing the toy to mother and like making a play, social games just like peekaboo, pat a cake. So depending upon the functioning we'll understand. If the child is coming to us at 3 or 4 years of age, functioning somewhere around 2 years, where there is no language, so we work on the language development. So in language also there are different areas. Is the child able to label? Is the child able to achieve functional language? So depending upon the child's need, definitely it should be tailor made. We should work on the deficits what the child is having. So there are different names.
Basically approaches what we want to suggest to parents is, it should be always like where your child is laying, what are there should be a proper goal setting for the child, particularly for your child, and they should work on a functional level, not the end level or the end target level, and there should be always a monitoring for this progress or whatever is happening with the child, and it should be always one-on-one. Therapist is to child,
and more importantly I need to speak here about the parent interaction.
Exactly, the therapy should involve the parent too. So you should go to a center where all this is being catered to you. It might be any kind of center, but any kind of approach for your child, it might be ABA, NDBI or any other name, but your child should be assessed properly. Then the goal should be set considering you into the therapy and your goals also into the chart, and should work with the child, including you.
The parents should work at home. 4 to 5 hours on ADL skills or interaction skills, because the bond or the interaction, the social language we develop from a natural setting, that is home. Definitely we get the language what our parents speaks, that's why it becomes our mother tongue. So parent interaction is 100% important. It's not like I have gone to the best of the doctors or best of the therapies or best of the treatments. Like best of the whatever, but still without parent interaction I don't think so we are going to see a much improvement in the children. It's not like I have taken to so many therapies, like from since morning to evening, school, OT, speech, behavior, so back to back, and like we keep the child so busy in the physical activity or some educational activity, that is never going to help the child or never going to help the parents. It's definitely one-on-one even with the parent. The child should have one-on-one even with the parent.
So the core message here is it is not like how many hours you are taking your child to a center, what kind of name the center is having, but your center should cover one-on-one therapies where your child is being functionally assessed. All the parts of the functionality is taken care of, you are taken care of, your needs are taken care of, and your targets are being taken care of, and you are being involved. And also if the child is a school going child, the school community is also included in this therapy and goal achieving progress. So you should select such kind of center, not the name or fame, or as she said, there is speech, there is OT, all these things. Hope this message is reached.
And my favorite part, bursting some myths. So it's very commonly heard. So I think it will be helpful for so many parents and people outside community and teachers. So
Shall we do a rapid fire?
Yeah. So is autism only seen in male children?
No, autism is seen in everyone, like male and female, both. But I think 4:1 ratio. If 4 males are affected, 1 female is being affected. Yeah, but the females are also affected.
Affected with autism. Second common myth is, does vaccinations cause autism?
No. Vaccination doesn't cause autism. Anni vaccines, MMR vaccine to saha anni ichukochu, em problem ledu.
Yeah. Does bad parenting cause autism?
No, bad parenting doesn't cause autism, but already autistic issue unna children lo, if you are not focusing on the child, if there is no one-on-one interaction and communication with the child, then definitely it increases the child risk for autism. Kani, there is no term called bad parenting. I think so. Yeah. Everybody is trying hard to be a good parent.
Yes, my favorite question, does screens alone cause autism spectrum?
See, so many pediatricians have this doubt. Screens alone doesn't cause autism. Indake cheppinattu, if the child is already at risk for autism, the child is having a problem with interaction and communication issue. So when you are showing the screen, there is a passive interaction that is happening. There is no one-on-one interaction. It increases the symptoms and it will make the child bring to us. Okay, but screen is not the cause for autism.
Yeah. Is every hyperactivity falls into autism?
No. Actually, this is my favorite question because ఇప్పుడున్న కరెంట్ సినారియోలో ఎక్కువ ఎర్లీ డయాగ్నోసిస్ చేస్తున్నాం. బేసికల్లీ టాడ్లర్ ఏజ్ గ్రూప్ లో తీసుకొస్తారు. టాడ్లర్స్ విల్ బీ హైపర్ యాక్టివ్. ఎవ్రీ హైపర్ యాక్టివ్ చైల్డ్ ఇస్ నాట్ ఆటిస్టిక్. Hyperactive child can be early risk for ADHD also. So it is not like every hyperactive is autistic.
Yeah. So is early diagnosis and early intervention is going to help the child?
It's a fact, it's not a myth. Yes, early intervention and early detection will lead to early intervention. It is moving children. 35% of children has moved out of the spectrum. These are not my words. This is the scientific studies saying that if you are doing that early intervention, especially below 3 years, because of this neuroplasticity thing, your child brain will develop up to 80% till 3 years of age. So our time lo, if you are doing the early intervention, one-on-one conversations, communications and all the therapy things, definitely 35% of children has already moved out of the spectrum. That is what the science is saying and the studies are saying. So it's a fact.
So is ADHD and autism spectrum same?
No, not at all. ADHD lies as a comorbidity with autism kani ADHD is completely different. Okay, ADHD child is not compulsorily autistic అవ్వాలని లేదు, బట్ ఆటిస్టిక్ చైల్డ్ కి ADHD ఉండొచ్చు
As a
comorbidity. So it's a కొంచెం ట్రికీ టర్మ్, కానీ ADHD is completely different. దానిలో జనరల్ గా 6 years తర్వాత మనం ఐడెంటిఫై చేస్తాము. మోస్ట్లీ స్పీచ్ డిలేస్ వాళ్ళకి ఉండవు. ఇక్కడ మనకి వచ్చేసరికి లాంగ్వేజ్ డిలేస్ ఇక్కడ మోర్ కామన్. ఓకే, అండ్ ఇంటరాక్షన్ అండ్ కమ్యూనికేషన్ విల్ బి గుడ్ ఇన్ ADHD, but not in autistic child. So these are the differences.
So can they go to a regular school, or every ASD child needs a special school?
No. So this is a myth only. Based on the functionality of the child, again, if the child is having good or high IQ or highly functioned autistic child, they can go to a normal classroom according to the age group. Kani, if the child is very low functioning, the social skills are very much hampered in the child, then they definitely require inclusive schools. They require resource room support system. ఇవన్నీ కావాల్సి ఉంటుంది. So yeah, every child doesn't require inclusive schools. Every child doesn't go to normal school. I mean, every autistic child
doesn't need not to be. So one more common myth I have observed is parents get confused with autism with intellectual disability also. Like a previous term like mental retardation. Is it same?
No. Basically, when I'm explaining the child symptoms to the parents, when I'm terming this autism, they'll say brain anta baane undi kada, IQ baane undi kada. So definitely your IQ is not going to get disturbed. Your social skills and your learning is getting affected in autism. So definitely the functionality of the child will be decreased.
So every child who is diagnosed with ASD, do they need MRI, EEG?
So one thumb rule for before diagnosing is now is BERA. Ante kani EEG, MRI is not required unless and otherwise if they are having a comorbidity like seizures, okay, or there is a global developmental delay, or if the child is a preterm, okay, all these things, then EEG, MRI is required according to the symptoms or the presentation of the child. But if the child is having only language and communication interaction problem, thumb rule is go for BERA, not for EEG or
any blood test can diagnose ASD.
No, ippudaka a blood test is not, but genetic testing is suggested for this X-linked diseases kani, Rett syndromes, Fragile X, all these are there kani, but they are not like for further baby planning kani, further child planning unte, then we can suppose the child or the parent to ask for a genetic test, but there is no particular blood test which says that this child is having.
And if we feel they might fit into some autism mimics.
Yeah, exactly. Yeah. When there is a supportive history, then go for a blood test or a genetic testing. When there is a reason, okay, but there is no specific test which diagnose autism.
Yeah. Does bone marrow going to help in treatment of?
No, a big no. Recently also IAP has said not to fall into this. So only as we told, one-on-one interaction, communication, and getting help from parents or the society and also the school community will help the child to do better in his life, not your stem cell therapist. No.
And there is a government GO which is passed that doing bone marrow for ASD kids is offensive. Okay.
It is most painful procedure also, Kirti. Yeah. So before considering stem cell therapy, you go through all this GO and everything because the child is going to get a lot of pain and everything. Yeah.
So can you throw us some light on virtual autism?
So as we said, screens are causing more raise in the number antunar kani, and they are coining a term called virtual autism, but that is not a definitive diagnosis. Autism spectrum disorder is the definitive diagnosis matrame, but the screens are increasing the passive communication. That's it. If the child is at risk for autism already, and if you are showing the screens, the risk will be increased. Ante. There is no term called virtual autism. Atla anukunte, if you stop screens, then the world will be so beautiful. But when we were very young, in the screen time ledu, but still there were autistic children then too. Yes. We should think about that too. Yes. So there is no...
Maybe it's only going to affect the functioning of the child. He's not going to improve the functioning, is going to be more maybe at the same level, without interaction. So anything else for me?
So epigenetics is causing your autism.
So as much as the scientific research or knowledge we are having on today, the epigenetics is the reason, main
chunks. Okay, most chunk of autistic children are from this.
Yes. And what are the comorbids we see with ASD children?
So very good question, Kirti. Endukante lot of children will have this comorbidities after certain age group. Okay, so the first important comorbidity we can see is ADHD. Almost 80% of the autistic children do have this attention and focus issues, hyperactive issues. Then comes your OCD, because they are attracted to some ritualistic behaviors or repetitive behaviors, they might land up in OCDs, obsessive compulsive disorder.
And all these children might present to us with behaviors.
Yeah, exactly.
Aggressive behavior.
Aggressive, maladaptive behaviors, self-harming behaviors, hitting others, biting, hitting their head banging. Yeah, all these things, all this comes under your behavior part, and then anxiety and also depression, and most common other than ADHD is sleep disturbances and also constipation, because they do have lot of sensory issues. They might be landing up in chewing issues and everything that might lead to that might lead to, and also tactile issues might also lead to your constipation.
And also sleep has a major role even in normal children. It's not only the autism spectrum children, those who are like sorry for using the term normal, in normal children also sleep disturbances might cause age appropriate functioning children also, because of sleep disturbances they might have behavioral issues in school. Yes,
so all these are comorbidities we can observe, and along with this most recently I have seen seizures, allergic rhinitis. All these are some of the common comorbidities
commonly seen, but we do see. We do see. So one more myth, can they wait?
No, wait and watch myth is not there. So in pediatrics they have removed it. As early as possible you identify it, make a move and go. We can wait 6 months, we will wait, we'll put in a normal school, we'll send them to school, they'll observe other children and they'll gain the language. That is not there. So as early as possible, when you identify these red flags, go to your pediatrician, explain them what you have observed, and take the necessary steps whatever the pediatrician is guiding you. If a developmental pediatrician is available in your city, then you go to them also. That is what I feel. So So we will end this video with some tips to the viewers. So the first tip I want to give is, as early as possible, if you are identifying all these signs or early signs, early picking up, early detection, early intervention, better result. That is the first and foremost important tip. What else you want to say?
Definitely screen the children at 18 and 24 months. The easy tool we have explained is MChat or any other tool. It's already printed in our OPD files and OPD books. So definitely screen the children at 18 and 24 months, and we can suggest some parental interaction tips when we see the child as early as 9 months, 10 months itself. Awareness to the parents, also the importance of screening.
No, screens will not cause autism, and also you should not wait and watch. Whenever you feel that this is all because of yourself or because of screens, you will wait and watch, you'll put in normal school. No screens or no bad parenting will cause autism. Any more tips you want to give for the parents?
Yeah, don't introduce screen till 2 years of age. No screen, no child should be exposed to any kind of screens, no TV, no iPad, no phone till 2 years of age. Even children who are above 2 years, the recommended screen time, we call it screen diet. It should be only half an hour per day, and it should be under parental monitoring also. And when the child is watching the screen also, it shouldn't be monotonous. They can make it as a play, give meaning to the cartoon or whatever the child is watching, or they can practically do a role play at home. So definitely even the screen time should have some interaction of the parent, and that also we should like make it into some positive this thing to improve the child's interaction and social language skills.
And also one more important tip to the parents who are having autistic children: always go to a therapy center where it is one-on-one and the functionality of the child is being identified, and they are supporting the strengths and difficulties of the child, and goals are being set and parents are being involved, and also if the school part is taken care of or not. And especially there is a developmental pediatrician who is guiding the team for all these things, right? So this kind of therapy might help the child, not the other therapies.
As because April 2nd this year, we are going to start a parental WhatsApp group to share your achievements, to share your child's progress, or any common myths and facts you want to know, or any advice. So there are pediatricians also included in that to guide the parents, and to bring up a parent support group in our locality. It will be given to the parents so they can add. The admin will help you with the process.
And also you can share your experiences with your child, how you are facing, what kind of problems you have. Not like any major problems you are facing, or you are traveling, you need any contacts, such kind of things we can provide.
Correct guidance even through. Yeah.
So, correct resources and correct guidance will be provided in that WhatsApp group, right?
Yes.
So we are ending this podcast. If any pediatricians are interested in this neurodiverse children, you can enroll into this chapter called Neurodevelopmental and Behavioral Pediatrics, and I'm the AP State Coordinator for the same. So you can forward your questions to all of us, so we can answer more on this topic or any other topic you require. Thank you so much.
Thank you.